Black History Month healthcare advocacy education in regards to vaccine and educating our Black and Brown communities. As Greater Baltimore Urban League strives to provide the key pillars of direct service, advocacy, education, and referral services to our Baltimore communities, we recognize the urgency in regards to providing information due to our pandemic and COVID-19. As the pandemic continues to provide, ravish our communities, we are excited to host this as a part of 2021's Black History Month in partnership with the Baltimore Metro Panhellenic Chapter, representing the Divine Nine, a Greek lettered organization. Our organizations are committed to serving all. Collectively, we provide information, access, and support to those in need. We are bringing you this information to have a real, transparent conversation with our educated physicians and professionals. I welcome Dr. Jadan Phillips, Dr. Nicolette Lusant, and my soror, Dr. Kathy Hardwick. Thank you so much. Please enter your questions in the chat box. We look forward to you being educated and making more informed decisions in regards to yourself and the communities we serve. Thank you.
Good evening, everyone. My name is Dr. Kathy Hardwick. I am Medical Director of Belongings Health Services, and I am here with two of my colleagues so that we're in line with the mission of the Greater Baltimore Urban League. To serve the community, we invite our guest speakers, Dr. Nicolette Lusant, who is the Executive Director of Healthcare, Ready, and also Dr. Jadan Phillips, who is the Medical Director at Stony Brook University School of Medicine, as well as a member of Omega Psi Phi Fraternity Incorporated, where he serves on the COVID task force. Tonight, our discussion will include a lot of things that we really want you to come in and discuss with us because you have questions we don't know. We're going to talk about COVID facts. Yes, we're actually still in the pandemic, as well as vaccinations. What are the myths that we really hear? What do we need to dispel in order to make sure we can make an informed decision? As well as Dr. Jadan, as well as Dr. Nicolette, will share more information on the variances that we keep hearing in the news or in other media outlets. At this time, we're going to start with Dr. Nicolette Lusant about COVID facts. What are the facts that we actually need to know at this time?
And I just want to start by saying thank you for having me. Always nice to be with my Urban League family. So when we think about what we need to know about COVID, first and foremost, I think it's important to lift up the fact that yes, we are still in the midst of a pandemic. We may be tired of it. It is not tired of us. We should also understand that many of the strains that we are talking about right now, and I know we'll get to variants later, are highly contagious. So understanding the best methods to actually avoid transmission of COVID includes some of what we call non-pharmaceutical interventions, washing your hands, social distancing, wearing masks. There is a lot of material right now that suggests that 2 masks are truly better than 1 if you wear them properly. So proper mask wearing is important as well. I'd say the final thing is that what we should also remember is that while we have a vaccine, we also have therapeutics. So as we're thinking about how we are treating individuals who are managing COVID-19 illness, it is important for us to note that there are therapies that can assist with your body's ability to fight the disease, but also the goal is to get us all vaccinated, hopefully by the end of the year.
Dr. Jadan Phillips, do you have anything that you would like to add?
Well, good evening. Very honored to be part of the panel, especially for Baltimore, where I spent a large amount of my formative years going to college at Johns Hopkins and going to University of Maryland Medical School. Again, you know, another big thing, again, is just being able to be in a position to come back to where you grew up and give back good information. As Dr. Lewis Saint just said, this pandemic is still ongoing. And unfortunately, this pandemic has exposed that Black and brown people are the low-hanging fruit when it comes to this. A lot of this, unfortunately, is related to our pre-existing health metrics. We have higher degrees of obesity, higher degrees of heart disease, higher degrees of stroke, higher degrees of diabetes. In addition to that, we tend to not be engaged with a doctor on a regular basis, which unfortunately, as Dr. Lewis Saint just mentioned, there are therapeutics that are out here, and to engage or be able to utilize them, such as something like a monoclonal antibody, you have had to connect with a doctor. And, again, that is unfortunately another aspect of why we are the low hanging fruit. Now, again, some people, and probably not from our community, look at those metrics and say, wow, look at what Black and brown people are predisposed to. But I think another aspect of this that is very critical is understanding what racism has played in this, understanding what systemic inequalities have played. Again, one of the motivations for me becoming a physician growing up in Queens, New York, was that I did not encounter quality medical care in my community, and definitely did not encounter medical providers that look like myself. So that was a mission that I wanted to address. And unfortunately, the mission is still here in 2020, going into 2021, because we've seen, unfortunately, because of these factors, they have led to us being more vulnerable, leading to higher rates of mortality and morbidity in our communities. And unfortunately, this has carried over. As Dr. Lewis Saint mentioned, we do have therapeutics, but even with that, we also now have a vaccine. And even with having that vaccine available, unfortunately, there is still a lot of skepticism, rightfully so. Unfortunately, people have still been experiencing, mistreatment by the medical system, which has historically happened. We've also, again, being in Baltimore, about Henrietta Lack and other similar type of circumstances where we were used as guinea pigs or unknowing study participants in medical research. But again, these things are factors that make us very apprehensive about considering this vaccine. But I think that is what COVID is banking on, that we do that delay. And in doing that delay, as Dr. Lewis Saint just mentioned, these new variants or new types or variants of COVID, unfortunately, are more infectious. And with them being more infectious, that means that even with practice and safety measures, it is still very easy for you to get COVID, especially if you live, as many of us do, in a got to situation. I got to go to work. I got to take public transportation. I got to live in this house where I may reside with my mother or my children. So again, we've got all of these other variables that are playing a role. And these are things that are contributing to the high level of situations that we're seeing in our community. So I think this conversation right now is critical because unfortunately, even though I listen to Dr. Fauci all the time, Dr. Fauci can't go into Dr. Lewis Saint's house and convince her friends, even though he may be saying the right things, because they trust and they know her. So I think it's important that we take this moment for us as providers of color to get in the middle of this conversation, answer the questions, and clear up any misconceptions. Because even though there's a rightful skepticism, this is what COVID is banking on. And if we do nothing, as they've speculated, we could be up to 700,000 deaths by April or May. Now, that means that we were at 200,000 deaths by about November. And between November and now, we've more than doubled the amount, which means that things have been going on an upswing. Even though we've seen the numbers come down in the recent weeks, unfortunately, this holiday season and these lessons that we've been talking about for a year as far as being able to restrain ourselves has not occurred over the holidays, because most cases of COVID are coming from social gatherings that are unsafe. And unfortunately, the holidays and the cold weather makes it even more challenging, on top of the fatigue that people have, on top of the mental anxiety and depression associated with this. So I think this conversation right now is critical, and I'll yield my time at this point.
All right. Dr. Lewis Saint, I'm wondering then, what about what the community, their education? When we go to them and they say, well, I've been doing just fine with elderberry and taking my vitamin C and my airborne. What about those patients who really, really are doing the right thing with boosting their immune system, but are not taking the risk to wear masks because they're thinking about those other home remedies and things that they're doing to stay safe?
Sure. And I just want to point out that while that is definitely happening, I've seen a shift and I want to acknowledge it. I've seen a shift where people are saying I can do both, and it doesn't have to be that I can rely on holistic only and I have to be so, anti-medicine that I can't wear a mask. And so I want to thank all of the people who are doing that for themselves, for the people connected to them, because that is an important shift. I think the other thing we're hearing a lot about is vitamin D, I want to say. So yes, you can certainly take vitamin D. As with most things, too much of it is a problem. I'm hearing about people taking 5,000 IUs of vitamin D. Please don't be that person, but you can certainly take, the holistic natural supplements to boost your immune system. And that's exactly what it's going to do. But it's not going to prevent you from getting infected. So again, there's a both and approach. That means that you can take your elderberry, you can take your supplements, and you can wear a mask to make sure that you are also complying and preventing the virus from entering your body. So there are two things that are happening. And I think it may be easier to think about it this way. Goal one is not getting infected at all. And elderberry is not going to help that. But if we have on a mask, if you social distance, if you're using sanitizer, if you're washing your hands, that's preventing your body from getting infected at all. If you get infected, your body's ability to fight off the virus, that is where those holistic remedies may be able to assist. So right now, what we're talking about is part number one: how can we avoid infection? If you're in a situation like Dr. Phillips was describing, not everybody can stay at home. Not everybody can be at home in an environment where everyone else is staying at home. So if you're in that environment and you need to make sure that in addition to those things, you're also boosting your immune system, go for it. As long as it's safe, as long as it doesn't interfere with other medications or other treatments that you have, that's fine. But goal number one is not getting infected.
I was
Could I add to that?
I was speaking with one of my sorors last week, and she mentioned houses of faith and believing that, because I believe in God, I won't get COVID. I mean,
Right.
I really want to discuss that, because we have some strong faith leaders in the community that we also want to support us. Can you speak on that, either Dr. Lewis Saint or Dr. Phillips?
Well, I was just going to piggyback what Dr. Lewis said first. And I just want to say this: there's no data that shows that COVID is prevented by these mitigating, strategies. So again, if you've been fortunate to this point that you haven't got COVID, God bless you. But again, there's been nothing that has been shown by the data that is going to prevent you from getting COVID. I do agree, as Dr. Lewis Saint said, it could be a double-pronged approach. The now is, we got to start to protect ourselves. The W's are important: washing your hands, wearing a mask, watching your distances, etc. But also, now that we have this vaccine, that is another factor to it. I think the second part of it is, as we look at ourselves and see, unfortunately, that we may not be in the best of health now, over this past time, you've got to start a plan of how you're going to become healthier. Because again, there may be another pandemic down the road. And with these health issues, unfortunately, they put you at a higher risk. You know, again, I remember someone telling me a story. This is to answer your current question, Dr. Hardwick. And it was a story about a God-fearing man that was living in this valley, and there was a dam that was, you know, there was a storm, and they said the storm was going to rupture the dam. So the sheriff of the town was going around and telling everyone, you need to get out of your home and go to a safe space, go up to a height because the dam is going to break. And the guy said, God is going to send me an angel. The water starts to rise a little bit. The sheriff comes back around the second time. He says to this farmer again, sir, you need to get you and your family out of here because the dam looks like it's imminently going to break. And if it ruptures, everything and everybody's going to die. The man said, God told me he's going to send me an angel. Unfortunately, the dam breaks and the water floods the whole valley. The guy dies with his family. He gets to the pearly gates and he says, God, I thought you were going to send me an angel. He said, I sent you two. So my point is, you know, again, I'm sure Dr. Lewis Saint, like myself, God has aided us in this process of becoming physicians. God has, again, helped us to have the abilities to, you know, gain this education that we're sharing right now. But the other thing that's happened over this pandemic is that you have seen clergy die from COVID. And at the end of the day, like I said just before, if you don't respect COVID, COVID is going to make you respect it. It don't care who you are. I think we just lost a mega church man of faith recently that just passed, you know, and unfortunately, sometimes I feel the media's desire to keep things at a low, we don't hear as much. Now, I have good friends that are in the clergy and they share with me how many of theirs have died. So I say that to say, God gave you these mitigating factors to help you deal with this. If you don't want to deal with it, you know, again, unfortunately, you got to deal with what comes because COVID is waiting for people to do the double dutch, which when I was younger, my sisters would jump double dutch with my cousins. And one of my cousins, she could never jump. And she would always be the one sitting there like this, trying to get her rhythm. And unfortunately, you see a lot of people right now doing that with respect to this vaccine.
Sounding
and
real
that
Queens
delay,
right now, Dr. Phillips.
huh?
Sounding real Queens right now, talking about double dutch.
Well, born and raised in Queens, and unfortunately, 11369 was the epicenter in March and April. So after I got off of work every day, I had 10 to 15 virtual patients that I had to take care of because I'm a son of that community. I've seen people die on FaceTime because they couldn't be taken to the hospital because of what was happening in the hospitals at that time. So again, you know, if we hesitate on utilizing some of these resources, the other part that we've seen is vaccine tourism. People coming from other communities that may not have spoken that they would get the vaccine, may not have seen that they were in favor of it, and they jumping right into your spot because you delay. So I think, again, that's something that we really need to think about.
So
Absolutely.
I just want to quickly jump in and first say Brooklyn girl, born and raised. So as you were watching your zip code, I was watching where my family still lives, 11210 Kings County, really battling the pandemic and also trying to figure out how to have daily health needs met. Dr. Hardwick, on your question about the faith-based community, I think I'm gonna be honest and say it's so much bigger than churches. Because when we're thinking about how people are intersecting, it's not necessarily just the Judeo-Christian model of church that has to be addressed.
Yeah.
I have seen churches take a range of approaches, and we've been working with the faith-based community at the national level for really the last year.
Mm-hmm.
And if you think about where we were last year, the question was even, can we have church? What will it look like to shut down? And if you're shut down as a church and you're doing virtual, what does it look like to keep the doors open? Because are you going to be able to tithe? Are you going to get that revenue? Are you going to be able to still continue? And so there was a very real business question that butted up against the public health question, as with other parts of society. But what we've seen in terms of the faith community, specifically the Black church, is there's an important intersection about what we knew about comorbidities and health prior to COVID. So we knew that if we were dealing with addressing diabetes, cardiovascular disease, obesity, we needed to start in the Black church because the rates were higher there. And so it's natural that if those are going to be the places where we would see higher comorbidities that actually make your outcomes from COVID more likely to be towards morbidity or mortality, you're going to see higher rates of death. But it's also important to remember that you can do all the right things and still get COVID. And you also need to remember that COVID manifests in different people in different ways. So it is difficult to predict how your battle with COVID would be, but it's also difficult to predict that if the one time you forget to wash your hands is going to be it. So the reason I say that is we also see a lot of churches that are grappling with how to do certain things safely, how to deliver ministry safely, and that may be where the risk is. So it's not only their responsibility to make sure that information's coming in, and I would also say in the later phases of vaccine rollout, we're likely going to need to see churches step up and actually offer their spaces to assist with vaccinations, because we need to go to where the people are. And if they're going to church, that's where we need to be. But I think the bigger question is, in the interim, how do we allow for churches to be able to deliver ministry that we need right now? People need food. People need to be able to have that additional support. They may need the clothing drive more than ever. So we've got to figure out how to do that safely. And that's been a big thing that we've been working on at Healthcare Ready, making sure that there are plans for that, because what we want to make sure of is that while they're doing all of this safely, they're not putting themselves at greater risk as well by trying to help and now getting infected.
Okay, my next concern then, when we talk about the COVID vaccine, we have presently the Moderna vaccine that we can get from our primary care office, and most of the healthcare workers getting most of the Pfizer vaccine. But then you have some of the people kind of midterm and that are waiting for the Johnson & Johnson because they feel, oh, it's more safe. Johnson & Johnson is kind of synonymous with children. So what information would you give a person who is grappling with, okay, maybe I might think about getting the vaccine, but which one is better? Dr. Lewis Saint, would you want to start us off with that one?
Sure. And just cut me off if I go too long, because this is where I spend a lot of my time. So I want to first start by saying we may not be able to choose which vaccine we get. And so it's really important that in a world where we have multiple vaccines, the goal is to get everyone vaccinated. It's not to get vaccinated with the Pfizer vaccine or vaccinated with the J&J. So shots in arms mean safely approved products going in arms. It's not going to be one or the other. But it's important to note that, and I want to bring this up now because there's a lot of concern about how the vaccines were developed. As somebody who is in what's called the biosecurity space or that health preparedness space, there's a framework that allows for us to be able to develop these vaccines quickly. That has nothing to do with who is in elected office. It has everything to do with a framework that has existed for about 15 years that allows for us to say, this is what we need to know. And we've had prior coronavirus outbreaks, not of this strain, but prior coronavirus outbreaks, most recently what's called MERS-CoV or the Middle East Respiratory Syndrome coronavirus outbreak around 2014, 2015, that was actually the science that is the backbone of these vaccines. So first and foremost, you can't choose your vaccine. Secondly, you can trust it because it's not that it was just developed in a few months. The science that goes into the backbones of understanding the technologies is actually quite old. But also, part of the reason that we are continuing to do more work on these vaccines and understanding them is because we're now trying to expand the populations that would be eligible for the vaccine. There's a lot of work going on to understand pediatrics and pediatric vaccination. So there are trials going on now that we know that these are safe in certain populations. There are trials going on to understand pregnant women and how to manage vaccination in pregnant women. And at that point, it is possible that one of the vaccines may perform perform better in some of these specialty populations than others. And so for those populations, it will be very important to understand that. I've gotten a lot of questions about autoimmune diseases, for example. But when it comes down to it, the goal is getting vaccines, understanding that based on phases, we're trying to actually upend the system that we've been using all along and actually introduce equity into how we are vaccinating, which means that for the first time ever, we are actually thinking about it from the vantage point of those who are most vulnerable getting access to vaccine first. And that is upending the system in a way that I think actually gives reasonable mistrust, because there are a lot of people that are looking at it and saying, well, this has never happened before. Why are you suddenly giving me the new thing first? But it's actually because we know that these things are safe and we know that they are protective. And so the goal is to make sure that we are protecting these communities first and then actually moving down the phases by risk.
Dr. Dejan, any comments?
What I would say is, again, we're not accustomed to being in the front of the line. And this is a new thing, but as Dr. Lewis Saint said, they're using a more public health approach, which is directing the treatments and support to those that are affected most. I think that also speaks to when people say, does this vaccine work in Black people or does it work in people that have diabetes or these comorbidities? And they have been robustly researched within the population. I think a plug that I would put here is we need to get involved in research. They did have in both Pfizer and Moderna about a 10% African-American population, which is higher than what we normally participate in medical research. And Hispanic numbers were about 13 to 14% in both, which is a robust amount when it comes to the amount of people of color. In addition to that, they also have not shown any side effects that are specific to Black and brown people, or that the vaccine doesn't work in Black and brown people as well. The only difference I'm seeing right now is Black and brown people are not the ones getting vaccinated. We're actually the lowest amount of groups in the United States. And again, when people are talking about getting to that point where we can start to relax things, or herd immunity, which is when 70 to 75% of the general population of the United States is either vaccinated or has had COVID, we're not anywhere near. I think we're at less than 10% of our population being vaccinated right now. Actually, I believe Israel, which is one of the top 3 nations in the world, they are about 70% of their total population is now vaccinated. So again, we are slowing things down, and I understand it. I mean, again, you can't start talking about the vaccine sometimes if you don't acknowledge the historical mistreatment. But unfortunately, that delay, as I mentioned earlier, is what COVID, especially these new variants, are banking on because of the increased infection rate.
Dr. Hardwick, can I just jump in for 1 second, because Dr. Phillips said something really important, and I want to use this opportunity. If we're talking about medical mistrust, I think we've got to go all the way in. So if we're going to talk about where medical mistrust comes from, and we talk about certain things, and it's funny because I am resisting the urge to bring up certain studies, but the reality is that for every study, there's probably 2 or 3 others that us as medical scientists may know, but may not be popular. I talk about thalidomide all the time, and the thalidomide study and what that did to pregnant women. And really the reason I do that is because it's important to first understand that the science and the regulatory process that we exist under today is not the same as the science regulatory process that existed in years past. And that is important because I think, for one, we need to understand what protections exist for patients and what things like the institutional review board process, the IRB approval process, means for how we actually not just look at what the final data may be, but the approach, the populations, how they're being recruited, what type of information is being provided, how we're providing informed consent, all the way through to what the legal protections are in a clinical trial. And so I think when we talk about mistrust, we assume that people understand that the constructs that we're under today are different. but we don't often say it. And so I want to be explicit about explaining that if some of the things that we often talk about as being historical mistrust happen today, people would be in jail.
Yeah.
It is actually under the current law wholly illegal to do many of those things that we consider to be mistrust, because the regulatory frameworks simply do not allow for that. So when we talk about things being safe, it's not just under the context of it's been the same system operating the same way over time. It's also in the context of there's a different legal framework and there's a different lens and a level of rigor and analysis that is put not just into what comes out of the study, but how patients were treated, what level of care they were provided throughout, how they're cared for after. That is actually a critical part of how a product is approved.
Okay. Well, that's good. It kind of segues into our initial question. We have a question in the chat saying this is a direct quote from a fellow Black person. There are 4 strains of HIV in the vaccine, and that's why Australia stopped using it. Now the people are being tested, and it's false negative for HIV. Please dispel this misinformation, as well as give us an intelligent response to those type of comments regarding the COVID vaccine. Now, I need to first say that the IRB, the things that you have to do even to get into research so that you can start it, would knock this myth, out of the water, because it has to be safe before it even gets to a human. We have gone through so many phases of testing in order to identify, well, you know what, this has worked this time. We've repeated it so many times, and then now we think we have enough data so that we can present it to someone. Can any of you speak on that before we get to the second question?
I'm not aware of any components of HIV. Now, the one thing I would say to that is we should not allow being vaccinated to make us lax on our protective measures. And I think, again, people that are thinking just because they've gotten vaccinated, they could be like Hank the Tank in Old School and just abandon all their safety measures. I think, again, that is not the case, because you need to be still one that adheres to those safety measures because of the limits of the ability for the vaccine. Again, you've heard stories about the nurse that got sick after the first shot. You don't get tested for COVID before you get a vaccine. So theoretically, you could have been exposed to COVID and be in an asymptomatic phase of it, or be an asymptomatic carrier up to that point, and then been vaccinated and then get sick. The other possibility is you could have not, stuck with the safety measures, and it takes a period of time after the second shot, usually about 2 or 3 weeks, for you to reach a level of immunity that can fight off the virus. And again, more specifically, the vaccine does not prevent infection, it prevents serious disease. And as we know, COVID, unfortunately, the only way it kills you is by you getting serious disease. And that is where the vaccine is effective. However, theoretically, even though it can reduce the amount of vaccine in the environment, you could theoretically spread it to someone else. So that's why it's still important, until we get to that point where we're in that herd immunity, that we, even vaccinated, we still need to mask up and practice those other safety measures.
Okay.
So this misinformation. So it's amazing to me the amount of garbage that people come up with on a daily basis to discourage people from doing what's in their best interest. This particular question, as a former HIV researcher, is especially irritating to me. First off, we talk about 2 strains of HIV, it's X4 and R5, so that's nonsense. But if we're actually going to talk about what's in the vaccine, one of the things that's interesting about these vaccines is that part of the reason this cold chain is so important is because there are so few components in the vaccine that there are no preservatives in it. So when we think about what's in the vaccine, there's really about 4 components. There is the actual vaccine itself, the mRNA vector. There is sodium chloride. there is basically vitamin C, which is often a preservative that's given, and then there's another diluent that's basically isomolar water. So we're not even going through a long list of here are the 15 things that are in it. There are 4 things in these vaccines, and none of them are HIV. So I think, you know, what I found on misinformation, sometimes challenging people on where they're getting their information, or just saying, here's what is true, because it does travel fast. That is the one thing I will say. I've seen misinformation travel faster than I would have ever imagined. So my response, and I would just say, for those of you who have the right information, don't wait until the trusted expert is on Facebook to do this. I don't have energy for it. Most people who are in the middle of the response don't have energy for it. We need all of you reminding people that this information exists, that it's out there, and that what they are pointing to is actually misinformation. You have to call it out.
Okay, the next question is, Dr. Janan, what would you say to people who are skeptical, either of you can answer, regarding the vaccine based on the reports of death and people receiving bad batches?
Well, as a person who has gotten the vaccine, and I got the Pfizer, I'm actually going on a month after my second shot. I'll turn around and stand up. I don't have a tail. I only have 2 arms. I trust the science. And the one thing I do know is COVID and what it can do. As Dr. Lewis Saint mentioned about Brooklyn, and I know about Queens, we have seen communities that are still reeling from the COVID pandemic, and that is the certainty out here. And as I tell people, how much longer do you think that you can keep traveling and going about your regular day and you keep avoiding COVID? So the other part is, if you want to see your family, if you want your kids to have some normalcy, we've got to invest in this space that we want to see. And part of that investment is the vaccine. Because again, they said if things don't change, April, we're going to be at 700,000. So what that means is if we do nothing, if you don't get a vaccine, and we do nothing, then things are going to get worse. Now, fortunately, we've seen the numbers go down recently. Now, what are the things that they're attributing to that? I think the model and the leadership that we have now with masking has been very helpful in making that a more standard sort of operation of behavior. I think, again, the other thing that's contributing to it is people getting vaccinated. I think last week there were at 1.6 million people a day that were getting vaccinated. So again, even though we're still not at 10%, those numbers of people getting vaccinated are making a difference. I mean, we are fortunate that we're in that time of the year where you start to see an ebb or decrease in viral illnesses. And I think that's playing a role. But I think also another aspect of it is the fact that because of there's all the resources moving towards getting vaccinated, we're not seeing as much availability of the testing sometimes. So that too could be, contributing to the numbers going down. But I do think, again, that we've got to consider, why were we the low-hanging fruit? And if you're a person that has any of those conditions that we mentioned earlier, and you think you can elderberry your way through this, I don't know. And especially if you are in a got-to circumstance, I don't know how much longer. So I think when you make this decision about whether or not you get vaccinated, you've got to not just look at yourself. You've got to look at, like for myself, I have a wife, I have a son, I work in a medical setting, both inpatient and outpatient. So I had to make a choice. Was I concerned about the vaccine? Yes, I was anxious, but I recognize that I've been chosen, as W.E.B. Du Bois talks about, that talented 10th. We are that talented 10th that has to participate in educating the 90% of us. So I'm willing to be the guinea pig with the vaccine, to be the testimony, because I know I got hoods behind me that trust me, and because they'll be like, yo, Jay, because you got it, I'm gonna get it. But I do think, as Dr. Lewis Saint says, we got to check this misinformation, y'all. Sometimes I feel like we're a person that's in a abuse abusive relationship. You know, you got individuals that are in those abusive relationships, and because they're afraid, they don't want to step away from that. And I think some of the PTSD that we experience because of this existence in America has created that fear. And it's easier to go with the misinformation sometimes than take a chance. But I do think that there is good information that supports the people trying, using this vaccine. And again, we would not be on here doing this. I mean, all of us have families and other things, but we all realize how critical the messaging needs to be in coming from people that resemble or come from the communities that are showing this skepticism. So I think that it's something that is critical.
All right, we're gonna go. I'm gonna kind of segue this question with allergies. We found that the only allergy that we're really concerned about is the sorbitol allergy, correct? So if you have a seafood allergy, tree nut allergy, those allergies are fine in respect to getting the vaccine. I do want to discuss, there was also a question in the chat talking about FDA approval. Can you touch the emergency use of the vaccine?
Sure.
Dr. Lewis Saint?
Sure. So, and it's interesting because the emergency use approval ties into how we manage it in the supply chain, which ties into how we can be sure that we are managing and testing for quality. So there are a few so when I talked about the framework earlier about how we accelerate development of a vaccine, what this is considered, COVID or anything like this, the avian flu, for those who remember the avian flu, it's called an emerging infectious disease. It's something that we've not seen infect humans before, that now, because of changes and whether those changes are people being around those livestock or those livestock having viruses that mutate in ways that now can infect humans, we now have a new virus, new disease that we've never seen before in people. And so this entire framework is a part of how we are able to develop medicine that can help fight against those emerging infectious diseases. That's what gets us to an EUA. So what the emergency use approval process does is it uses components of the FDA, our regulatory authority, the CDC, our public health ministry, and the data that is coming in from the companies to actually go through a set of reviews. So the first review outside of the study is to say, yes, we believe that this is effective, that we have safety data. So first and foremost, the question is not, does it work? It's actually, is it safe? And so once we understand that it's safe, then the review for the EUA says, does this safe product have benefits that outweigh any risk? And what should we understand about risk? And that is what is presented to make a determination about an emergency use authorization. What that does is it doesn't bypass any of the traditional FDA approval measures. It accelerates them. So that means that all of the regular regulatory delays that come with the bureaucracy of government are eliminated, recognizing that we don't have 2 years to wait to have those hurdles normally met. And that really is bureaucracy. The rigor of the analysis is actually more rigorous, understanding that it's going to be a product that goes into the general population. It's not the only products that have ever been under EUA. Products can be under EUA for a few reasons. One is it's a new product, but the other is it may be an old product that's being used in a new way. So sometimes we'll see instances where there's an emergency use for a product recognizing, for example, dexamethasone, which is being used in treatment of COVID-infected patients, that was being considered under EUA as an example. And so what the EUA means is that there's an emergency use authorization. That is a full application and actually a set of applications that the developers have to put into the FDA. That is then reviewed. And actually the Johnson & Johnson review is happening on the 26th of this month. And then there's a decision that is made. They still have to apply for approval. They still have to continue work. And not every EUA is a yes. So it's important to also remember that what the EUA process allows is for the review, and the determination is that it is safe and that the benefits are great enough that it should be used. That's what happens. And in the EUA process, there's also language about which populations are safe to get it, how it should be administered. So that's why you see that one vaccine, for example, has a 21-day window, the other has a 28-day window, because that's how it was done in the trial, but also how it should be managed and transported. And so as a supply chain person, it's important to know that those products are not just moved and we hope for the best. They actually have tracers in the boxes that allow for us to make sure that pressure is right, temperature is right, no water's been introduced. And what those boxes do is they maintain the integrity of the product. And if any one of those things is wrong, that product is not used. But all of that is a part of how we review and understand the safety and efficacy of a product in the EUA process.
Okay. Now we're coming down to the end, and I really wanted to touch base on this because there's a lot of questions regarding variants, especially in light of the new one that they had in the North Atlantic region this recently. What would you say regarding the South African, the UK, and the Brazilian strains? Either of you can answer.
Well, what we've seen thus far is that they've demonstrated that they're much more infectious. So again, as Dr. Lewis Saint mentioned earlier, the newer recommendation with double masking, the other mandate that anytime you're on public transportation throughout the country, you have to have a mask on. We didn't have that before. So I think with this higher infectious rate, again, it provides, unfortunately, an easier opportunity for individuals to get this pandemic, to get this virus. And I think it provides another reason why you should consider getting vaccinated. As far as the vaccines, there's really been no data to say that as of yet, the Moderna or the Pfizer doesn't work against these strains. I'm not going to talk about J&J because they haven't been approved yet, or AstraZeneca, but the ones on the market in the United States, they have not been shown not to work. I think another point to make is that the sooner we have more people vaccinated, the less opportunity for mutation. So I think another point that we need to consider as far as getting vaccinated, if we are afraid of the possibility and the potential of these mutant strains.
Okay. Any commentary, Dr. Lewis Saint, before I move on?
So we're seeing the UK strain move a little bit faster across the US. So the concern right now, and the UK strain is highly infectious. It is in almost every state in the US, but we are expecting that by the beginning of March, so the first week in March, we'll be at what's called community spread of the UK variant in the US, which is concerning because that does mean that with our vaccination rates being as slow as they are, we do have to be concerned that people will have a more infectious strain of COVID in their communities and will not yet be vaccinated. So that's the one that we're tracking the closest, recognizing that it is already predominant in the US, and the expectation is that it will be the predominant strain globally very soon because it is so infectious. So that is what we're looking at. The South African strain also raising some questions, but we are expecting that studies that should be complete in about the next 4 weeks will tell us exactly how the vaccine candidates perform against these variants.
Okay. Do you have any additions before we move on to the question in the chat? There's a question in the chat that says that many school districts around the country are opting to return to traditional in-person education without the mandatory vaccination or access to the vaccine for the staff and students. What are your thoughts about going back to traditional education, to the traditional education model, and what is it potential effects, adverse effects, or indications? What's indicated for that? Either one of you can start.
Oh, I was going to let Dr. Lewis. Okay, I'll go.
All right.
I have a 12-year-old, and he's been hybrid consistently throughout the year. You know, I think one of the things that we've seen is that the schools have actually been a safer space than the surrounding communities as far as the rates. Now, again, you know, this is a part that's difficult because as Dr. Lewis Saint mentioned earlier, with the prioritizing of the vaccine and its effect on those that are most susceptible, people say, well, why aren't the children a priority? Because the children are not usually the ones that are going to get very sick. So again, this brings another, but the children are the big spreaders of this. And unfortunately, a lot of the people that are teaching in the schools are not some of the healthiest people, and those medical conditions that I mentioned earlier, again, if you want to work in that space, I think, and be safe about it, I think you've got to consider getting yourself vaccinated. I mean, I understand the selfish concern or skepticism, but again, if you're in a got to category, then this is something that you need to consider. The CDC is releasing guidelines now with respect to the schools and the recommendations. But again, I think this pandemic has shown it with our children that it's been a disabling. It's taken away our elders and it's disabled our young people. And again, we have seen, because I may be fortunate, my son is up in his room, he can Zoom, he's got his own space to do his TELUS virtual learning, but I realize how blessed he is. And most children that look like me don't have that availability. So we are seeing that, unfortunately, this pandemic is, as a person who grew up in New York in the 70s and 80s, and I saw crack, and I saw how crack took people off the table, meaning their ability to be productive moving forward in their lives was taken away from them because of crack. We're seeing the same potential in this situation. We're seeing young people. I just saw an article yesterday of pediatric children that do virtual learning, 30 to 40 pounds gaining over the past year. Kids that I've seen in the office, I can't believe the weight gain that I'm seeing. However, again, these are the challenges. Unfortunately, you're seeing other kids that are not able to maintain those skill sets that are needed to be a successful student virtually, and it's costing them. So I think we've got to consider all these variables when we just say, I'm scared and I don't want to go back to work. Because when I first had to go up into the hospital or into a clinic or patient setting, I was scared too. But I think, again, I always look at scare or fear as that fight, flight, or fright response. That's your body getting ready to handle some business. So that's how I looked at that feeling of anxiety that I had when I was first going back. And I'll tell you this, 2 days ago, I went to a pop-up vaccine site in one of our communities, and I was the medical consultant for the day and spoke to probably about 300 elders. And I was able to do it compassionately and effectively because I was vaccinated. Even though I wore a mask, I was able to do my job with a confidence that gave that touch that people needed in that moment. And I would challenge our educational professionals, because Dr. Lewis Saint and myself, we are doctors that look at this. This is our Super Bowl. Yeah. This is for doctors, like in New York, for 9/11, the policemen and the firemen, that was their moment where they showed that they was about that life. Right now, that's why we're here right now, because her and I are about that life. And I think that our educational professionals, if you want to still have that job and be protected, I think you've got to open up your eyes and your mind to consider this vaccine, because if you don't, how much longer can you go and not get the UK strain?
Okay, so before we finish for the night and give the polls to everyone that came, we have one other question, and someone actually listed all the ingredients for the Moderna vaccine in the chat. Can you speak to the question? I was told by the darker your pigmentation, your skin, or the darker the pigmentation in your skin, the harder it is for the COVID vaccine to work. Your body tends to reject it. Is that a myth along with the other myths?
So I'll take that myth, and I'll take the question on the components as well. I saw it come in there, and I appreciate the fact that first and foremost, you could pull up the component. So I did not misspeak. What I did not do was clarify that when I say like the mRNA vaccine, what you'll see in there is polyethylene glycol, lipids, cholesterol, and a stabilizer. All of that is the actual mRNA, because you can't just put the mRNA freestanding into liquid. By the time it gets injected, it would be destroyed. So that is the mRNA itself is encapsulated inside of that polyethylene glycol that's stabilized with those components. So that I considered as one component. So a little lazy in my communication, and I apologize for that. But that, when you look at those things that are in there, those first, I believe it was in that list that she gave, those first few are actually all about what's the mRNA is encased in, and that's what's in the vaccine. So on I am always amazed, because I always hear more stories and misinformation every time I have these conversations. I've never heard this one before. So no, there is no truth that the darker your skin tone, the harder it may be for your body to absorb the vaccine. The vaccine is being delivered subcutaneously. It is being delivered under your skin. So it is not actually going to interact with the surface of your skin. It's going into cells that are going to then kickstart your immune system. Our immune system has no color. So no, there is no bearing to that bit of misinformation. It is actually all about, it has nothing to do with pigmentation. It's all about your immune system's ability to recognize that mRNA vaccine once it comes out of that polyethylene glycol, to then say, okay, we're gonna make that protein. The mRNA is only carrying a message. That mRNA is going to carry that message, and that message is going to tell the cells in your immune system to make a protein. And once it makes that protein, your body is then going to build immunity against that protein. And that protein is the same protein that would be on the surface of coronavirus. So there's no bearing on that.
All right. Well, thank you so much for coming, Dr. Jadan Phillips. I really, really appreciate you, as well as Dr. Nicolette Lusant. You've been absolutely wonderful. Thank you so much for your clinical research. It's truly amazing. We had a wealth of information. Thank you all. Please, please, please take the poll at this time. I'm going to turn it over to my soror, big sister, and colleague, Soror Nicole Cameron.
Good evening, everyone. I hope you can hear me okay. I was trying to go on video, but I may be having some technical problems. I apologize for that. But nevertheless, I want to say a big heartfelt thank you to all for attending this wonderful event. To my dear number, Dr. Jadan Phillips, thank you, thank you, thank you. I know you have to hop off at 6:58, a great time to do so, but thank you for giving your time, your knowledge. Dr. Lewis Saint, make sure I said that correctly. We appreciate your blessing us with your presence this evening. We know that you guys are all frontline. Dr. Kathy Hardwick as well. So making time to be here with us this evening is a humble, humble blessing. To the president of the Baltimore Metro chapter, Clarissa Jackson, thank you for bringing your team and supporting us in this event. Follow us on Instagram, follow us on Facebook. We plan to have plenty of events. Our CEO, Ms. Majors, is back on live. I see her on video. So we welcome the opportunity to do other events like this. We know this is the beginning of many, many important sessions. Knowledge is power. We're hoping that we leave here learning something new. If we had a question or a myth, hopefully we dispelled it and we answered it, and share that with your family and your loved ones. Again, thank you.
Thank you, Dr. Phillips.
Majors,
Thank you, Dr. Lusant. We appreciate your support and time. And we
Dr. Lusant.
Absolutely amazing, amazing information for us. So
Brooklyn
thank you
in the house.
Absolutely.
Right.
You said
Queens is
Queen,
here
so
too,
I
though.
had to do it.
It's all good. The Q borough was
Wonderful.
always there
Really
too, so it's all good.
Thank you
Howard
for
to
the
the
Black
people, baby.
doctors and providing that information to our Black folks. We appreciate it.
Thank you.
Thank you.
Thank you.
Have a good
And
night.
continue to be safe and wear your mask, shorty.
Yes.